Hello, I'm Peter Johnson. I'm the Professor of Medical Oncology in Southampton, and I'm going to talk this morning about the management of Hodgkin lymphoma in 2020. I'm going to give a short introductory talk about some of the results from the recent clinical trials, and then we'll move into questions and answers, and I hope do some case presentations and discussion about those. So if we summarize the overall results of the treatment of Hodgkin lymphoma, we know that with modern treatment, we can cure at least 90% of patients with the first line of therapy we use. That's higher in the early stage disease and less so in the advanced stage disease, but even there we expect to cure around 85% or more of patients with our initial therapy. Furthermore, we expect at least 85% to be alive 10 years from the time of diagnosis, and this of course reflects that this is predominantly a relatively young population with an average age at presentation in the UK of around 30 to 35. And of course the older population are more difficult to treat, and we may talk about that later in some of the case presentations. The recent trials interestingly show that in many cases there are more deaths from other causes than Hodgkin lymphoma, such as infections, such as second malignancies, and such as late cardiovascular disease. And it's important to note that control of the lymphoma and overall survival are not necessarily the same thing with this illness, and this reflects the very high efficacy of salvage therapies and things like autologous stem cell transplant in second remission. So the primary focus of our endeavours at the moment remains to improve the results of initial treatment, because of course people would much prefer to be treated just once, but at the same time to have an eye on and to minimise the long-term toxicity of treatment, because we know that people would like to avoid this if possible, and it puts a considerable burden of morbidity and indeed mortality for patients with Hodgkin lymphoma who we're often treating at a very young age and who have many years of life ahead of them. So some of the important questions for us in this day and age are, firstly, is combined modality treatment, the combination of chemotherapy and radiotherapy, essential for all patients with early stage disease? And secondly, in advanced stage disease, how do we select the optimum first-line chemotherapy for the patients we're looking after? Should this be with conventional chemotherapy? Should we be considering the addition of antibody drug conjugates such as brentuximab vedotin? And whereabouts do we see the role of anti-Pd1 antibodies fitting in? Very importantly, in considering our approaches to Hodgkin lymphoma, what we would like to be able to do is to distinguish worse from less threatening disease in order that we can tailor the intensity of treatment that we use accordingly. And we can do this using different measurements. For example, baseline clinical features such as the well-known International Prognostic Score, or so-called Hasenclever Index, and the results of this kind of analysis, which segregates patients into 7 different risk groups, are shown in the top right-hand figure here, where there is clear separation, but even the worst group still has a progression-free survival, a rate of around 60% or so with modern therapies. Are baseline biological assessments helpful? At the moment, I'm afraid probably not. We've done a good deal of work on immunohistochemistry and gene expression profiling to see whether we can understand better about the biology of those cases where the outcomes are going to be less good. And there's certainly emerging data about gene expression profiling, but none of it is ready for routine application as yet. The baseline feature, which I think may be increasingly helpful, is the metabolic tumor volume, which is essentially an integration of the degree of glucose avidity measured by FDG PET scanning and the volume of the lymphoma that we see at the baseline. And certainly this seems to work very similarly to stage and the International Prognostic Score in predicting the outcomes of treatment. But by far the most influential predictor of the outcomes of treatment is the response to treatment itself, as measured by interim PET scanning. And the panel on the bottom left here illustrates the difference between 2 cases, where both of them scanned after 2 months of treatment with ABVD, where on the left-hand side you can see there's complete metabolic remission, and although there is residual abnormal soft tissue within the mediastinum, this is completely non-glucose avid. Whereas the case on the right still has a very high degree of uptake. This is a so-called Deauville 5-point score of 5, and this patient with continued ABVD is likely to have a very poor prognosis. And the data, which was published now a long time ago, on the right-hand side at the bottom here, illustrates the difference in prospective outcomes between these two groups of patients, with the FDG negative group having very good outcomes, even if their baseline prognostic factors were adverse, and the FDG positive group having very poor outcomes, even if their baseline prognostic factors were favourable. And we've been using increasingly interim PET scanning to guide the modulation of therapy and to tell us whether we could adjust treatment in order to fit the response. And of course, the principal reason for wishing to do this is to avoid some of the important late effects as our likelihood of cures go up, and as I said, as people are likely to live longer and longer with the consequences of their treatment. And certainly when thinking about early Hodgkin lymphoma in this young population of patients where radiotherapy to the mediastinum is often used, these are some of the late effects that we would like to avoid if possible. In the top left-hand panel here, you can see the markings for a young woman who has had extended field radiotherapy, the mantle field, which unfortunately encompasses a significant amount of breast tissue. And we now know that significant radiation of the breast under the age of 30 increases the risk of breast cancer significantly in later life. Similarly, the panel at the bottom on the left here shows an occlusion of the left main stem of coronary artery, again, just on the border of a mediastinal radiotherapy field in a patient who'd had treatment for Hodgkin lymphoma and mediastinal radiotherapy subsequently. And the bottom right here shows you radiation-induced aortic stenosis as seen on an echocardiogram, and this is an increasing problem that we see. The endarteritis and the inflammatory responses to irradiation of the mediastinum around the coronary ostia and the aortic valve is a problem which we increasingly see in our late follow-up clinics and which we would obviously like to avoid. So these are some of the figures which again have been published in recent years, indicating the potential risk of second malignancies in response to different eras of treatment. And you can see that the cutoff here is still before the year 2000, and at that time we were still using rather more extensive radiotherapy fields than is currently the case. But nonetheless, what we can see is that the observed versus affected incidence of second malignancies in patients who'd had particularly mediastinal radiotherapy really hadn't come down very substantially as we'd reduced the radiotherapy fields during that period. And we're hoping that the further reduction that has been carried out since 2000 may improve these results and may lessen this risk. So this is the risk of second malignancies, and you can see that the cumulative incidence goes up to around 30 or 40% with 30 to 40 years of follow-up. Similarly, if we look at the incidence of coronary heart disease, these are the figures according to the amount of radiation given to the coronary ostia. And you can see that compared to the curve at the bottom here, which is the likelihood of significant coronary heart disease with increasing time of follow-up, and again, we're going out to 35, 40 years here, the bottom line is with no radiotherapy, and the top line is more than 25 gray. But you can see that there's a dose-response curve here in terms of the likelihood of coronary heart disease. And again, we would much rather avoid this if we possibly can. So to summarize the problem for early stage Hodgkin lymphoma, and the PET scans on the left here are from a young woman that we looked after in Southampton, I think this illustrates the problem very nicely. Although this is confined to above the diaphragm, this is stage 2A disease with which this young woman presented, nonetheless there are multiple sites of involvement here, and you can see that to encompass all of these with a radiotherapy field following chemotherapy would result in irradiation of a very significant part of the mediastinum and potentially the base of the heart as well, as the radiotherapy field needs to encompass that disease which you can see lower down on the right-hand side of the mediastinum. So the question then is, do we have to give this more extensive and potentially toxic treatment to all the patients who might be cured by something less harmful? And that something, of course, potentially is a chemotherapy alone regimen in early stage disease. And if you look at the numbers and the differences that we've seen in recent randomized trials, there's a recognition that radiotherapy does reduce the risk of recurrence to some degree, but for every patient avoiding a recurrence after radiotherapy, we put around 10 to 20 at risk of the important long-term toxicities that I've already referred to by this combined modality approach. So the number needed to treat is somewhere between 10 and 20 for all the data that we have at the moment. And again, to re-emphasize, most deaths in this group are due to causes other than the Hodgkin lymphoma, which are potentially avoidable if we can avoid the long-term toxicity of treatment. So how can we use personalized medicine to respond to this in the modern era? And of course, the progressive reduction of radiotherapy fields, which is shown here, is one way by which this may be done. And what this illustrates, going from left to right on this slide, is the reduction from total nodal to regional to involved field to increasingly involved site radiotherapy. And at the same time, we've reduced the radiation dose from 30 to 40 gray to 20 to 30 gray for people receiving combined modality treatment. And we hope that this might be sufficient to reduce the long-term morbidity. And certainly in selected cases, there's a high expectation that this may be the case. But the obvious logical conclusion of all this is, can you leave out the radiotherapy altogether and still get comparable results in the long term? And these are some of the randomized trials. Two of them reported some time ago. The RAPID trial, mainly done in the UK, but also some centres in India. The H10 trial, done as a collaboration between the ERTC and Italian Hodgkin study groups, and the HD17 trial carried out by the German Hodgkin study group. And to some extent, these ask complementary questions. So the RAPID study, patients received 3 cycles of ABVD, then had a PET scan carried out, and if that was negative, they were randomized to no further treatment, so they got a total of 3 ABVD, or involved field radiotherapy. And patients could only go into the RAPID study if they didn't have bulky disease within the mediastinum. In the H10 study, they were stratified according to the baseline characteristics, which segregate favorable from unfavorable disease in the ERTC classification, and mostly this is about mediastinal bulk, ESR, and B symptoms. And you can see that there was a randomization which was carried out initially before any treatment was given to a PET-driven approach or to a standard approach. And for favorable disease, the standard approach was 3 cycles of ABVD with involved node radiotherapy. And for the PET-driven approach, it was a PET scan after 2 cycles of ABVD. And if the PET was negative, a further 2 cycles with no radiation. If the PET was positive, they escalated to BCOP and had involved node radiotherapy. For unfavorable disease, the standard approach was 4 ABVD and involved node radiation. But if they were on a PET-driven approach and the PET was negative, they simply received 6 cycles of ABVD and no radiotherapy. And finally, in the bottom panel on the right-hand side, the German Hodgkin study group similarly randomized patients up front for if they had unfavorable disease, they had BCOP escalated and then 2 ABVD as their standard approach to treatment, and then involved node radiotherapy. If they had a PET-driven approach, those who were PET negative after 2 BCOP escalated and 2 ABVD went on to have no further treatment, whereas those who were PET positive had involved node radiotherapy. And they carried out a similar study, the HD16 study, in favorable Hodgkin lymphoma, where they had 2 ABVD, and then again followed a PET-driven or a standard approach where they had involved node radiotherapy or not, according to the PET scan. So these are the trials that have been carried out, and let's see the results of all those different studies. Well, these are summed up on this slide here. Firstly, we have the RAPID study, where the event-free survival was 96% with involved field radiotherapy after ABVD, and 90% after 3 ABVD alone. In the HD16 study, and remember that's favorable early Hodgkin lymphoma, where they had just 2 ABVD, and then if they were PET negative, they had no further treatment. There was a difference between 93.4% and 86.1% in progression-free survival. So again, a reduction in progression-free survival, giving a very short course of ABVD and omitting the radiotherapy altogether. And in the favorable group in the H10 study, who had 3 ABVD and involved node radiotherapy versus 4 ABVD, again, the chemotherapy-only arm had a significantly worse progression-free survival. And this was in some ways the most striking of all the results, with a reduction of 12 percentage points overall from 99 down to 87. And I think most people recognize that the experimental arm in this study with 4 ABVD seems to be doing very badly compared to the arm, for example, in the RAPID study, where 90% remained event-free after 3 ABVD. So this is a little surprising. If we look at the unfavorable groups, We can see on the bottom left the H10 study, where patients got either 4 ABVD and involved node radiotherapy or 6 ABVD and no radiation. And there was a very small difference in progression-free survival, which does not reach conventional significance. Similarly, in the HD17 study, where patients got 2 cycles of escalated BCOP and 2 ABVD before having or not having radiotherapy for those with unfavorable disease, again, the results were largely superimposable. So what we can see here is that the favorable group have some reduction in progression-free survival if we leave out the radiation after quite reduced chemotherapy, whereas in the unfavorable group who have more adequate chemotherapy, the results are much more closely overlapping. And what this suggests is that, at least for those with unfavorable disease, a full course of chemotherapy may be a preferable approach to the cut-down approach or to the combined modality treatment. And if we look at the overall survival after de-escalation in these PET negative groups in these studies, what we can see very reassuringly is that survival rates are extremely high, both in favorable and unfavorable disease, with overall survival of 98 to 100% in all these studies. And that's obviously very encouraging, because what it suggests is that the small number of people who may be disadvantaged by leaving out radiation as part of their initial therapy have a very high chance of salvage and long-term cure. And I think that's an important point to keep coming back to, which is that even the small number of people who may be disadvantaged by leaving out radiotherapy can be effectively salvaged. So if we try to summarize the evidence for the management of early-stage Hodgkin lymphoma, I think we have to recognize that the highest initial cure rates still rest with combined modality therapy. And for early-stage Hodgkin lymphoma, that would be 2 cycles of ABVD and 20 gray of involved node radiotherapy. And for unfavorable disease, that would be 4 cycles of ABVD and involved node radiotherapy. But for the substantial number of people where the radiation may be a poor idea from the point of view of long-term toxicity, we think that therapy adapted according to the interim PET scan is a reasonable and safe approach, as I've shown you. And we should certainly consider those approaches where people have non-bulky disease at presentation, where they have a low metabolic tumor volume, and particularly if the PET is negative after 2 ABVD. And we think that those people with a low volume and a negative PET scan have a very high chance of cure with chemotherapy alone. If people have unfavorable disease, 2 ABVD and 2 escalated BCOP is a very effective initial approach, but similarly, a full course of chemotherapy with 6 ABVD may be equally useful. And these, again, we think we can omit the radiotherapy if the PET is negative after 2 cycles. And of course, most importantly, people in whom the anatomical distribution of the lymphoma puts them at high risk of either a second cancer or cardiac damage from involved field radiotherapy are those in whom we would most energetically wish to pursue this approach. We hope that with the introduction of more effective agents for first-line treatment, this soon may become an academic question. And certainly, as we've seen the efficacy of first-line treatment go up and be better matched to the prognostic features of the lymphoma, for example, by using 2 ABVD and 2 escalated BCOP for unfavorable disease, so we've seen the role of radiotherapy becoming progressively less important. So I think that's some important pointers about where we're going with the treatment of early-stage disease. What about advanced Hodgkin lymphoma? Well, again, we have the results from a number of recent trials which have been published in the last few years to guide us about the use of interim PET for the management of advanced Hodgkin lymphoma. Our own RATHL study, which was an international collaboration between the UK, Italy, and Nordic countries, is shown on the left, and that was published several years ago now. In the middle is the German Hodgkin HD18 study published by Peter Borschmann in 2017, and more recently the LISA group, the French group, which was published in Lancet Oncology last year. And again, some complementary trial designs which will help us, I think, unpick the optimal approach for this illness. Firstly, in RATHL, everybody commenced with 2 cycles of ABVD, and then after an interim PET scan, those who were PET negative were randomized between 4 ABVD, which was continuing normal treatment, in other words, or dropping the bleomycin, and those who were PET positive after 2 cycles of ABVD were escalated to a BCOP regimen, either escalated BCOP or BCOP 14. The German Hodgkin study group started treatment for everybody with escalated BRCOP, and after a PET scan, the people who were PET negative were randomized to reduce the number of cycles down to a total of just 4, or to carry on with the usual number of an additional 4 or in some cases 6 cycles. And those who were PET positive were randomized to continue with BRCOP or to have rituximab added as a means of trying to see whether altering the tumor microenvironment might be helpful. And finally, in the French group, everybody started with 2 cycles of escalated BRCOP. The standard therapy arm had 6 cycles in total. The PET-driven arm had de-escalation to ABVD after a negative PET scan or continuation of BRCOP for those who had a positive PET scan. And as I say, the results of these studies to some extent give us complementary information about the optimal approach to management. These are the results illustrating the control of the lymphoma after de-escalation of therapy in those patients who were PET negative after 2 cycles of treatment. You can see in the RATHL trial on the left here, leaving out the bleomycin after a negative interim PET scan made no difference to the progression-free survival, and the overall figure for this group was just under 82% at 5 years. In the LISA study, the French study, where everybody started with BRCOP but de-escalated to ABVD with a negative PET scan, again, no reduction in progression-free survival from this approach. And on the right-hand side, going down from 6 to 4 cycles of escalated BRCOP for a negative PET scan, again, no reduction in progression-free survival for this group in the German Hodgkin study group data. So overall, we can see that de-escalating therapy for patients with advanced Hodgkin lymphoma carries no disadvantage for patients. Interestingly, overall progression-free survival is higher in the studies that start with BRCOP than the one that started with ABVD. So it's about 90% with BRCOP as initial therapy. It's about just over 82% if we start with ABVD. So the initial control of lymphoma, as we've said before, is less good with less intensive chemotherapy. However, if we look at the survival figures, once again, these are very good for advanced stage disease, with all the studies showing around a 95% 5-year overall survival. And again, this reflects the fact that if people started with ABVD in the RATHL study, they were salvageable by BRCOP if they had a positive interim PET scan, and similarly, if they relapsed after a negative interim PET scan, they were readily salvaged, and the overall survival figures were very similar. And certainly the overall survival figures between the RATHL and the HD18 study, if we look at comparable age groups, are entirely superimposable. So again, I don't think it matters what regimen one starts with, provided we are ready to give salvage chemotherapy in the small number of people whose treatment fails as a result of giving less intensive therapy as part of the initial regimen. So if we think about the choice of initial chemotherapy, thinking about conventional treatment, it certainly suggests that treatment with escalated BRCOP will improve the negative predictive value of the interim PET. As I say, we see progression-free survival of around 90% after BRCOP as opposed to 80 to 82% with ABVD. And certainly it results in higher progression-free survival, but the influence on overall survival is less clear, and clearly it's much more toxic. It carries much more gonadatoxicity, a small risk of acute leukemia, and other factors such as accelerated coronary artery disease and pulmonary fibrosis. The de-escalation of treatment after a negative interim PET retains the efficacy of treatment, and although we don't have data from this on long-term follow-up, we anticipate that de-escalation of therapy will reduce morbidity and potentially mortality in the future. Whether this is omitting radiotherapy, which is something which was done in an Italian trial and again showed no reduction in progression-free survival for those who are interim PET negative, leaving out bleomycin as we did in the RATHL study, reducing from BRCOP to ABVD as was done in the French study, or reducing the number of cycles of BRCOP as was done in the German study. All of these are credible and useful ways to adapt treatment for patients who have a negative interim PET scan after the initial 2 months of treatment. And furthermore, the escalation from ABVD to BRCOP for those who were PET positive in the RATHL study appeared to carry a favourable outcome with around a 65% progression-free survival compared to historical figures of well below 35% from the continuation of ABVD. And so this is an approach that we've increasingly taken. The question then is, can we improve upon these results, and can we do better than this for our patients with particularly advanced Hodgkin lymphoma? I think it's fair to say that the results with ABVD in patients with relatively advanced disease at presentation, particularly those with stage 4 disease, with B symptoms, with bulky masses, with high metabolic tumor volume, these are less good than we would wish, even after a negative interim PET. And in the worst prognostic group, we see progression-free survival figures of just below 80%, even in those who are PET negative after 2 cycles. So starting with more intensive or more effective treatment feels like an important option for that group. We have new biomarkers coming through, as I've already alluded to, using PET scans to do total lesional glycolysis or metabolic tumor volume. We also have the potential to use circulating free DNA, although at the moment this is not ready for prime time use. We don't have prospective analyses of the effect of this and how we can use this in modulating treatment, but this is something that we're working on. And biomarkers such as TARC or other soluble cytokines may also give us an indication of the effectiveness of treatment, and a lot of investigation is going into those. And we're thinking about how we can combine those with interim PET scans, particularly to try and improve the negative prognostic value, to try and pick out those groups whose baseline characteristics or whose dynamic measurements allow us to be much more confident about a negative result from the interim PET scan. Obviously, we would like to find more effective forms of initial therapy, and I'm going to talk briefly about 2 potential opportunities for that in the remainder of this talk. And again, some of the newer agents give us the option to potentially find better approaches for those with positive interim PET scans, who we know from the studying the results of the series that I've shown you already have a relatively poor prognosis, even with the most intensive treatment. So the first approach, obviously, is the combination of brentuximab vedotin, the antibody-drug conjugate, as part of initial therapy. And the first study of this to report was the Echelon 1 study, in which patients with stage 3 and 4 disease were randomized between conventional ABVD given for 6 cycles and AVD given with brentuximab vedotin. So omitting the bleomycin and substituting this with brentuximab vedotin, again, giving it on the same schedule every 2 weeks for a total of 6 months of treatment. And notably, this study was not a PET modulated study, so patients could continue to receive the initial treatment that they were allocated, even if they had a positive interim PET scan, although there was the option for those with a Deauville score of 5 to come off the treatment and to switch to a different arm, although this happened in relatively few of the cases that were seen. And the primary endpoint of this study was initially set out as a modified progression-free survival by the review committee of imaging, for which events were progression, death from any cause, or a PET scan which was judged to be positive, that's to say 0.3 to 0.5 on the Deauville scale, after initial therapy, where subsequent anti-cancer treatment was given. And this was not a blinded evaluation. This was up to the discretion of the treating clinicians to decide whether to go on treating in the presence of a positive or deemed positive PET scan at the end of initial therapy. And this risks, of course, creating a certain amount of bias. These are the modified progression-free and overall survival figures that were reported in the paper in the New England Journal of Medicine, showing a small but definite advantage to the incorporation of brentuximab vedotin in initial therapy, although there was no difference in overall survival, and we saw significantly more neuropathy and significantly more neutropenic fever until we introduced G-CSF into the experimental arm to reduce the neutropenic fever. But the neuropathy has remained a significant finding, although in the great majority of cases this is reversible. And an initial subgroup analysis appeared to show that stage 4 disease was the group in whom brentuximab vedotin was most advantageous, although a subsequent reanalysis of this data set has not shown that and has suggested that stage 3 disease may derive a benefit from this approach as well. This is the 3-year follow-up data with conventional progression-free survival, so removing the subsequent treatment on the basis of a positive PET scan as an event, and we can see that the curves have remained apart with around a 7% overall percentage point difference between AAVD and ABVD. And in PET-positive patients, the progression-free survival was significantly different, about 16 points different, with those who had brentuximab vedotin doing much better, indicating that a PET modulated approach for those on ABVD might well have been a good idea, and escalation to something like BIACOP might have served them better than continuing with ABVD. And as I say, the subgroup analysis, which is shown in this plot on the right-hand side, indicated that there was a fairly uniform small advantage to the addition of brentuximab vedotin. And note that as I say, the stage 3 and stage 4 subgroup analyses both show an advantage in terms of progression-free survival. Once again, no difference in overall survival at this point in follow-up. The other new agent, which is being widely explored, is the Anti-Pd1 antibody. And in this case, it's nivolumab, although pembrolizumab, which is an alternative agent which has exactly the same mechanism of action, has also been studied, as I'll show you in a moment. And there were initial studies which have been reported some time ago now in patients with relapsed and refractory disease using single-agent anti-PD-1 antibodies, which showed substantial response rates for those patients for whom chemotherapy approaches had failed. And indeed, many of those patients were either continued on anti-PD-1 treatment for up to 2 years, or in some cases went on to have autologous or allogeneic stem cell transplants to consolidate their remission, which was very successful. Having seen these results, the next obvious step was to try and incorporate these agents into first-line treatment. And the first of these to report was the Checkmate 205 study run by the manufacturers of nivolumab and reported in the Journal of Clinical Oncology last year. And here patients with newly diagnosed Hodgkin lymphoma received initial treatment with nivolumab monotherapy for 4 doses at 2-week intervals, and then had reassessment with PET scans. Completed monotherapy provided they were responding, and then went on to AVD in combination with the antibody for the conventional 12 doses. And this was an interesting approach to see what would happen in response to the antibody alone and then the combined chemotherapy with antibody approach. And that's shown in the left-hand panel here. At the end of monotherapy, you can see that the overall response rate was around 70%, although the complete response rate was rather lower than this at about 20-25%. And the 2 columns are the comparison of local investigator analysis of the PET results and centralized review. But after 2 cycles of combination treatment, you can see that the response rates are up in the 90% and a much higher complete response rate. And at the end of all therapy, very high overall response rates. And the progression-free survival curve shown on the right here, admittedly with very short follow-up, only out to 9 months, looked very encouraging in terms of how durable these remissions were and the lack of early progression, at any rate, in this fairly selected small group of patients who were treated on this particular protocol. And the waterfall plot illustrates the degree of response at the end of treatment. So encouraging initial therapy, initial data with relatively short follow-up. This is some further data, again with relatively short follow-up, published with the combination of pembrolizumab and AVD in early unfavorable or advanced stage Hodgkin lymphoma, which was published a little earlier this year in Blood, showing, as you can see, an extremely good progression-free survival curve with a median follow-up of just under 2 years. And the PET scans on the left here, I think, illustrate some of the very profound responses to pembrolizumab. In the top 2 panels, you can see really quite bulky and extensive disease, which has become metabolically almost completely inert after 3 cycles. And similarly, on the bottom panel there, again, quite extensive disease, very good response with only low-level residual activity. So I think there is good evidence that these are highly active agents in Hodgkin lymphoma. I think the mechanism of action is probably quite distinct from that we see in solid tumor oncology. The rapidity of the responses speaks to an immediate effect on cell-cell interactions. And I think this is probably what's happening, that there's an interruption of the crosstalk between the malignant B cells, the Hodgkin-Reed-Sternberg cells, and the T-cell infiltrate, which is such a visible component of classical Hodgkin lymphoma. And this seems to be a highly active combination, and it's very encouraging that giving it in combination with chemotherapy seems to be so effective. So in trying to synthesize the available data that we have for advanced Hodgkin lymphoma, this is the kind of algorithm that we're currently following, although clearly this, I think, is going to change in the next few years as these new agents enter more widespread use. So for low-risk disease, we start with ABVD, and by low risk, we generally mean those patients who present with an international prognostic score of 0 to 2, and in some cases 3, where we wish to avoid more toxic initial treatment. We'll give 2 cycles of ABVD, we'll do a PET scan, and for those where the PET scan is negative, we de-escalate to AVD as per the RATHL study. In those patients in whom the PET scan is positive, we generally escalate to a BCOP variant. We've substituted procarbazine for dacarbazine in order to avoid some of the gonadotrophic and potentially leukemogenic long-term effects. This seems to be quite well tolerated. The alternative, of course, might be to escalate to brentuximab vedotin with AVD, although there's really no data at the moment to support this approach, and we continue to use the BCOP-DAC regimen. For those with a very high interim PET score of a Deauville 5-point score of 5, we know that even escalating the conventional chemotherapy carries relatively poor outcomes. And I think this is the area in which we would explore switching to a second-line salvage chemotherapy, such as gemcitabine, cisplatin, dexamethasone, with a view to going on to high-dose therapy in first remission, because these patients really do have quite a poor prognosis with continuing conventional chemotherapy. And again, this is a group in whom it would make sense to explore the idea of anti-PD1 prior to some intensification of treatment. For those with high-risk disease, and that's to say an international prognostic score of 3 or more, we certainly these days in the UK will consider starting with the BCOP-DAC regimen as our initial treatment. And in those places where there's a license and reimbursement, the addition of brentuximab vedotin to AVD might be an alternative approach for this higher risk group. Again, we use an interim PET scan to determine what to do subsequently. For those who are PET negative, we go down to AVD because we think this is equivalent to ABVD, and this is the approach which seemed to work very well in the French study, the LISA 2011 study. For those who are PET positive, again, continue with either BCOP-DAC or consider the addition of brentuximab vedotin in the so-called BRICAD regimen, which has been published by the German Hodgkin study group and seems to have useful efficacy. And for those with the highest PET scores, again, consider either salvage chemotherapy or potentially an anti-PD1 agent with a view to consolidation. So I'll draw to a close there by pointing out what you're all well aware of, that Hodgkin lymphoma is highly curable and that we need to improve the outcomes further, particularly for those with very high-risk disease at presentation, those with positive interim PET scans where we know that the conventional approaches are less successful, and a subject I've not talked about but which we might come to in the discussion, the older patients for whom at the moment there is no standard regimen, although we have some emerging data suggesting that the sequential combination of brentuximab vedotin and AVD may be one way to go, as has been illustrated from a phase 2 study in the United States. I think the optimal approach at the moment is to combine risk-adapted approaches to treatment. That's to say, considering the degree of risk at the baseline according to the international prognostic score, or potentially PET characteristics such as metabolic tumor volume or total lesional glycolysis, and also use a response-adapted regimen, modulating the treatment so that we tune down the intensity of treatment, whether it's by the omission of radiotherapy or by less intensive chemotherapy for those where the treatment is obviously having a very favorable effect on the interim PET scan, and potentially the escalation of treatment for those where the PET indicates a less good response. I think the new active classes of agent are particularly exciting, and I think the anti-PD1 antibodies are going to enter increasingly widespread use as we see more and more of these becoming available, and as the price comes down through competition in the market. I think combining these with conventional first-line chemotherapy is going to become the way of treatment of the future. And I hope that, as I alluded to earlier, this may make some of the discussions about the best thing to do as consolidation of initial remission maybe become redundant as we see more active initial treatment. Certainly, I think there's scope for testing these in sequence or in combination and using the interim PET scan as a means of picking out the groups where we need to change the approach to treatment is an excellent way of approaching this. So I hope that's given some food for thought and some scope for discussion, and I look forward to your questions.